Hello, I'm Donald McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Scotland, but I should really be more specific because we're in Glasgow and we're talking to Andrea Williamson, who has a most interesting title, Professor of General Practice and Inclusion Health. Now that's the bit that I'm really interested in. Andrea, tell us a little bit about your role, how you got there and the importance of inclusion health.
So how did I get here? That's an interesting question. So I've always been interested in the care of marginalised people. Even, I suppose, as a medical student, studied here in Glasgow, I used to be involved in running a soup kitchen for people experiencing homelessness. And then I did my GP training when I finished medical school and came back to the city of Glasgow after managing to leave for a couple of years. And yeah, and just I suppose I find clinical medicine interesting, and I enjoy the detective work of that. But what I've always quite quickly got interested in was, well, what about the people who are not being well served by healthcare as it is currently delivered? And I was lucky enough to do an academic fellowship here at the University of Glasgow, and I got to choose which clinical services I went to work in. So I spent a bit of time working in alcohol and drug recovery services, and I spent a bit of time helping what was then the homeless families team. And I just really became interested in the sort of the tricky stuff, the stuff around how do you ensure that people take up offers of care, do the health promoting things that they need to do. And so yeah, that I suppose that kind of then started me on a journey thinking, right, and during that fellowship I did my master's in public health and got switched on to doing research. I'd never thought in early career that I would end up doing research, but I really loved qualitative research. And then that led me on to thinking about my PhD as well. About 13 years ago now, I was involved in the early days of GPs at the Deep End, which was started by my colleague Graham Watt, who was head of department here in Glasgow. And really his thing was that GPs who serve the most socioeconomically deprived communities, they don't really have a voice in what's going on in terms of healthcare development and delivery. So he convened that group, and I think 14 years on, we're still going strong. And the Deep End movement has now become, it's now become a movement. There's now Deep End groups across the UK and beyond, globally now. And it's really focused on, the sort of care of patients in socioeconomically deprived communities. And I think that's been really interesting for me, because I tended to always think that a lot of the sort of issues that my patients encounter, and that as a health professional trying to care for people encounter, that was really something about sort of really extreme marginalisation. But what the Deep End sort of group has taught us is that actually it's an issue for lots of people struggling with adversity. So yeah, so I suppose that then led me to think, well, there's a sort of research and policy development often sort of happens in silos. So you'll get really great work being done to think about how you can best support people experiencing homelessness, or best support people struggling with problem substance use. And you can have really great policy and practice stuff going on in mainstream practice, but actually there's a lot of synergy, a lot of learning that can be gleaned from those different approaches. And actually there's something to be said for bringing it all together. And that's really where the inclusion health aspect comes in. And that's why when I was promoted to professor last summer, then that was what we thought was the best way to describe what my work involves. It's about trying to think about marginalisation across the piece and learn as best we can from lots of different disciplines to think about how service provision for people should be different going forward.
Now, you've hit the headlines recently. You had a headline across the national newspaper with some of your research. That was about the time that patients get. Tell us about that.
I mean, it's chasing that holy grail of how you identify and quantify unmet need. Because one thing I think that we're really good at doing as sort of health professionals is knowing what's in front of us, and work life. The health service is such a busy place these days that for people to have the headspace to sort of take a step back and go, right, okay, who's missing, what's missing? That's not always easy. And so when we were doing a big bit of epidemiological work looking at missingness in healthcare a few years ago, one of it's actually my colleague Alex McConaughey, who's who's the lead statistician on the team. He was like, no, there's more to this. We can actually use this data to have a think about unmet needs. And when we looked at, so we had done a really careful kind of coded long-term health conditions in the GP record. And when we looked at that, that's when we found that actually there is a big mismatch between the sort of time that GPs give in more socioeconomically deprived places than in more affluent places.
So the problem really begins in the consultation. So health access in the consultation is primarily a problem, even in deprived groups.
Well, in terms of, so people even managing to get in to see the GP. So I mean, there's a whole pathway there, isn't there? There's people identifying that they have a health need that needs met. People then feeling able to seek out care. Then people being able to take up offers of care if they can get that offer, and that's become the sort of really pressing problem since the end of since the COVID pandemic, is that increasingly people are really struggling to get access to general practice. And for people who have high health literacy, a reasonable amount of wealth, so that they've actually got money on their phone, the time and the sort of psychological robustness. It's not an easy thing to sit on the phone at 8:30 every morning trying desperately to get through to your practice. And the thing is, practices don't know who's not getting through. Practices don't know who's given up. So there's the health needs that people identify that they might need met that's causing them harm, but there's also lots of there's all the other unidentified needs, like all the sort of risk factors for longer term cardiovascular outcomes, for example.
Let me bring you back to another of your interests, which clearly began when you were a medical student, and that is alcohol and drug addiction.
So way back, I suppose that interest came from, again, I suppose, meeting the needs of people who were marginalised, and there's such shame and stigma still, although there's huge effort going in to try and shift that, but there's huge shame and stigma still around a person struggling with substance use, whether that be alcohol or other drugs which are still illegal. So that, I suppose, that was the initial interest, and then as my sort of knowledge and experience developed, I increasingly came to understand that when people are using alcohol and drugs, the vast majority of people who are dependent are using it to escape and cope. So they're using it to escape and cope with memories and emotions of often really terrible things that have happened to them in their past. And so I suppose, and so that then brings that really firmly, aside from the shame, stigma, and exclusion from services, that then brings that really firmly into the inclusion health context, because that is, I suppose, one of the commonalities that many people who we would consider to be an inclusion health population share, is that they've often, and I'm not wanting to stereotype, but I think that the evidence does tell us quite strongly that people often have had really significant adversity and difficulties across their life.
Well, we talk about the individual, but this is a whole public health political issue. I mean, and people think of general practice as being about the consultation, but the whole politics of healthcare really impinges on general practice. Things like minimum pricing of alcohol, policy on alcohol. Talk to me a little bit about your views on that.
For many GPs, their work life is about, it's about the consultation, it's about the individual patient in front of them. But actually, though, it really is, because most GPs help manage their practice, have got some sort of control over how they run their practice. And also one thing I think that the GPs at the deep end group has really taught us is that actually we have quite a lot of power. Our voices are heard. We have it is a, I mean, some people would say it's a bit of a cliche, but actually, and lots of other public sector professionals have similar, but we do really have unique insights into a whole range of people's lives across society. We meet people when they're at their most vulnerable. We know things about people that many people, even in their immediate family, might not know. So that kind of knowledge of people's lives is actually really important. And what we as the Deep End group have done is say, right, okay, that knowledge should be translated into advocacy, and we should be thinking about the things that are really important in terms of the population, in terms of public health. And I know not all GPs are comfortable with that, but actually what I think we've shown through the Deep End movement is that action can have power. So yeah, so we have as a group been active in supporting the minimum unit pricing strategy in Scotland. We've recently been involved in the call to have that increased because we feel that the amount needs to be increased because it has been shown to have positive public health outcomes. And in fact, we would go further. I think there's way more needs to be done in terms of alcohol policy in Scotland to help reduce the harms. But the flip side to that, though, is that we actually also need to be thinking better about how we provide care for people who are struggling with alcohol dependency, who do get tipped over. And, at the moment, I mean, there's lots of action and lots of sort of policy interest in moving things along. But really, in terms of services for people, it's still a bit of a postcode lottery when it comes to being able to access alcohol treatment services. And certainly we're still not, entirely, great at providing care that's, permeable and easy to access for people. That's for sure. And also, I think linked in with that is, and this has been said for decades now, but that the link between struggling with problem substances and then getting care and treatment and support for mental health issues is still not good at all.
Let me talk to you about another aspect, a higher level, let's call it, and it's equally a problem on both sides of the Irish Sea, and that's the whole area of the culture of alcohol in our society.
I think that's one of the really interesting things. I mean, it even comes up, you're teaching undergraduate medical students, and, obviously we have students who are from other country settings who come into the UK, and when we have discussions about alcohol, it just becomes obvious so quickly, and it's the same in professional settings as well, that people actually, that culture of alcohol as a pleasurable thing that is just so across everything that we do when we think about socializing, relaxing. And yeah, so I think it is really interesting when you're trying to encourage students and practitioners to be reflexive. So that's one element of it, and the other element of it is to do with issues around how we construct our social space, where the places are that people can go and meet, and again back to that sort of escape coping. How is it as a society that we escape? How is it that we cope with the challenges and difficulties of life? I know for sure life is very hard for a lot of people at the moment. And I suppose that's for me one of the things that I'm always struck, when I'm thinking about inclusion health and I'm thinking about sort of Deep End, is that, often the sort of resources and for people so that they can socialise or manage life, more easily in other ways. Those resources are just not as available in our Deep End communities, and it's harder to do things. And so it's all of those. There's so many factors to come into it.
I'm so impressed with what you do with the Deep End communities. What Graham Watt started and what you folk have continued. And the Deep End concept, of course, has gone far beyond Scotland. It's been taken up in many international communities. It's really wonderful to see that. And it's so positive. But I want to have a little insight into how you keep going when sometimes things go wrong. I mean, the closure of the homeless service in Glasgow, the problems with the link workers. How do you keep going? Give us some positive encouragement for our listeners and readers in keeping the whole machine moving.
The really short answer to that is that no clinician is alone in this, and that that thing we learn, we learn from our predecessors about actually collective action is really, really important. that is what keeps us all going. And for sure, each of us have our times where either individually or collectively things get really tough. And we feel like we're having to say the same things over and over and over again. But I think the thing that we've learned, it's been a fascinating learning curve for us all as a group, is that, politicians change, civil servants change, the policy framework changes, health colleagues within management change. And so you have to keep saying the same thing. But actually perseverance is a skill and is actually a really effective strategy. And so so even within the Deep End group, we've had people over the years who've either dipped out for a short time or done a bit of work and then moved on. But actually there's that core collective of people, we re-energize each other. That there is something really powerful about having your tribe. And I think that's one thing that the Deep End does, is it enables people who have maybe been sort of plugging away on their own or within a small practice or setting, when they come together, that means that they've got the backup, they've got the encouragement, they've got the collective skills. Because that's the other thing about the Deep End groups, they're all distinct. They all are basically a collection of various individuals with a range of skill sets who come together to try and make things better for Deep End patients. That's it in a nutshell, really. It is that collective action and that perseverance that makes a difference.
Andrea, it's been fascinating talking to you, moving from the personal and continuing care of the individual to the collective health activism and health advocacy. Continue with your fantastic work. Thank you very much for sharing with it today. Thank you.